Hello, everyone. Good evening. We welcome you to today's discussion on building stronger health systems for delivering universal health coverage lessons from a pandemic. Health leaks out of science and draws nourishment from the fabric of society, said Swedish Nobel laureate economist Gunnar Myrdal. Health is often viewed as an individual attribute, responsibility, or privilege to be enjoyed and tended to and addressed individually. The central role of a society's economic, social, and political systems in shaping and impacting the health of its populace naturally invisible in such a field. By 2025, India is poised to overtake China as the world's most populous country and become the world's third largest economy by 2030. The health indicators of our large country, however, lag miserably behind our economic growth and compare poorly with most of our neighbors. There are huge health inequities across socio-economic strata which profoundly impact our development and growth. The need to steer our national health policy towards strengthening our health systems and bridge these gaps has never been more urgent. Dealing with a pandemic in such a scenario is therefore multiply challenging. As we've been repeatedly told this past year, coexisting with COVID 19 is the new normal. The world, however, must prepare itself for the long haul before it settles down to living with COVID. COVID 19 has been called cataclysmic, but just to put things in perspective, the influenza pandemic of 1918 to 1920 infected about 500 million people, under one third of the world population at the time, and killed an estimated 40 to 50 billion. By November 2020, SARS-CoV-2 had infected 67 million people, less than 10% of the world population of 7.8 billion, and taken more than 1.5 million lives. Devastating as the human toll has been, undeniably, over 45 million people have been cured so far, and the vaccines have arrived. COVID 19 has not yet run its course, but there is optimism grounded in reasonable certainty that the human fatalities won't be anything like the world saw a century ago with the Spanish influenza. The smaller scale of destruction this time indicates vast improvements in public health, in nutrition, as also the ability of governments to respond. The world recovered from that pandemic, and there is no reason why it will not recover from this one. The question is, what will the recovery be like? Today's discussion between Professor K. Srinath Reddy and Dr. Abdul Ghaffar, two world-renowned public health experts, will revolve around issues and challenges thrown up by the pandemic, how policymakers and health systems have responded to the crisis nationally and globally, mitigation strategies, the role of government and non-government players in civil society, as also the importance of combining policy formulation and implementation with scientific research as well as ground realities. Dr. Ghaffar and Professor Reddy, thank you both so much for joining us today. Dr. Abdul Ghaffar is Executive Director, Alliance for Health Policy and Systems Research at the World Health Organization headquarters. He has worked in and for low and middle income countries for the last 35 years, designing, planning, and evaluating health systems, collaborating with policymakers, research forums, and training future generations of health systems leaders. His academic contributions advance the agenda of greater local knowledge for stronger national health systems. His goal is to trigger a global movement to generate and use scientific research for better policy decisions. Professor K. Srinath Reddy is the president of Health Foundation of India, AFI. He headed the Department of Cardiology at the All India Institute of Medical Sciences in New Delhi. Under his leadership, PFFI has established five Indian to advance multidisciplinary health education, research, health technologies, and implementation for supporting strengthening health systems. An advisor to the governments of Odisha and Andhra Pradesh on health, he has recently published a book with Orient Black Swan titled Make Health in India, Reaching a Billion Plus. Over to you, Dr. Ghaffar and Professor Reddy.
Thank you very much. As you rightly stated, this is a time for optimism, despite the challenges that we are facing globally. And today, particularly, has been a very important day in India's fight against COVID-19, when the two vaccines have been now launched into the general population coverage program, starting with health workers and other essential workers, and then it will cover groups who are likely to be vulnerable based on age and comorbidities. But nevertheless, the program has started and is offering hope of promoting widespread population immunity, which will help overcome this pandemic. However, it is also true that we are meeting at a time when this unprecedented pandemic, at least in our lifetime, has rattled health systems everywhere in the world. And it is somewhat paradoxical that some of the richer countries are the worst affected, whereas countries of South Asia and Africa seem to have done a little better. But all health systems everywhere have been challenged in one way or the other. And even as vaccines have arrived, offering a fair amount of hope, we also recognize that there are mutant forms that are emerging, which are becoming even more infectious in terms of their transmission dynamics and are posing fresh challenges in terms of control. We have also known that over the course of the year, we have learned and unlearned many things. We started off with a great faith in ventilators and some initial disbelief that masks are necessary. But then we started recognizing that masks are more important, oxygen helps, but very importantly, physical distancing or social distancing is critical, ventilation is important, public health measures outweigh even hospital care in providing the best response to the pandemic. But of course, all of these are complementary. But in order to ensure that all of these responses are effectively coordinated and efficiently delivered, we need a well-functioning health system. And that is where policy also needs to come in order to provide the right kind of mandate for the health system to deliver and also choose the right priorities. However, health systems have not always been in the forefront of policy consideration, and Dr. Ghafar's role in WHO is to ensure that governments and policymakers, as well as all other stakeholders in society, recognize the importance of the health system and also ensure that health policy is developed along fairly healthy lines so that we can actually provide a broad-based response. Dr. Ghaffar, given your vantage position in WHO, do you think that health has now garnered greater attention globally, and the fleeting attention given by policymakers, including those who provide the budgetary allocations, is now going to be replaced with a much more sustained commitment to the protection and promotion of health?
Good evening, Professor Reddy, and good evening, colleagues, ladies and gentlemen. So thank you, Professor Reddy, for highlighting that how the policymakers and the people who fund the policies are appreciating or recognizing the importance of health system. If it's a question of appreciation and the recognition, definitely the question is a big yes, because it is the unexpected and unprecedented attention and the focus which the health systems are receiving all over the world. Developing countries, rich countries, poor countries, everybody. And the reason is it happens very rarely when every person of society is concerned about safety and health of him or herself of the family or the community. So if we look at that, there's absolutely no issue that it is recognized. Every president of the country or the prime minister of the country understand it. However, your second question is, has it changed the commitment of the ministries of finance, ministries of planning, or even ministries of health? I think there we have to see, because the countries have different priorities, especially both into the low and high income countries. And you mentioned that this virus or this pandemic has rattled the health systems all over the world, and maybe more into those countries where we thought, quote unquote, they had the resilient health system, because they thought the countries in the low and middle income country settings are not, that they are relatively fragile. I think what we need to do is we need to keep on producing the evidence knowledge to convince the policymakers, but I think the more important is the pressure and the will of the community and the people and the population to make a case that we need more money for health as a broader allocation within the total GDPs of the countries and within the overall budget allocations, but also focusing on, with the systems lens, with the whole of government, than just investing into the vertical programs, which has been easier for the funders and the government to see the results. And the science of systems, like, I think it's a little bit more challenging, because most of economists can see efficiency and effectiveness measurements are much easier for the vertical or specific designated program. But the time has come, the country should invest more and more in systems. Otherwise, we are not going to ensure the safety and the health of the people.
Indeed, as you said, we need a much more coordinated systems approach. Even in the pandemic, we have seen, at least in the early stages, somebody looking at equipment, somebody looking at testing kits, somebody looking at also the idea of getting people for contact tracing. But none of these were really coordinated in a very planned and organized manner. And therefore, the health system itself appeared to have a fragmented approach, leave aside multisectoral coordination. Part of the problem also has been that with the Millennium Development Goals, which were well-intentioned, however, they broke the health agenda, particularly in low and middle income countries, into segments by disease and fragmented by age groups, only looking at some elements of health conditions like maternal and child health, infectious diseases, some of them, and also nutrition, but completely forgetting about non-communicable diseases, mental health, and many of the other challenges. The Sustainable Development Goals have brought in a much more holistic approach. And now we are talking even about universal health coverage, which is going to be principally driven with a strong primary healthcare infrastructure. Do you think this transition that has happened in global health from MDGs to SDGs, and now with universal health coverage coming very prominently into the fore, has really started reshaping the health systems to think about it in a more organized, holistic manner? Or are we still looking at it in a siloed, fragmented, vertical approach, which is going to really cost us in terms of efficiency?
So thank you, Professor Reddy. There was a time I was teaching in a school of public health, and I will tell my students that I'm genetically optimistic. So if you ask me, am I like, what is my confidence? I think yes. However, the reality is the people who are especially in the public health or health, they have realized that there was a Alma-Ata Declaration in 1978, which was comprehensive primary health care. And then some powers who are more interested to make investment and see the result, they change it to more selective primary health care. And with the same mindset, we have the MDGs, which has been targeting like particular conditions or diseases like child health, like malaria or the TB. And as you are saying, this is very important, and it has yielded some positive outcomes and the results, but it has compromised the overall performance of the health system and overall health of the population. And luckily, as you're saying, the world then realized and has committed to more like the sustainable development goals. And I believe there's a genuine interest within the development community, within the funders and the national governments to move towards that. However, the problem is nothing has changed either in the ministries of health or into the development agency. It's the same mindset, it's the same expertise, the people who are implementing MDGs, they have been tasked to implement SDGs. So it is just like nothing has changed practically, either the expertise or the direction, but the commitment is there. And with that commitment, I think there are more funds, there's more realization, there are more knowledge, there are more like case studies from the different parts of the world which are coming, and that's helping. And I personally think if the world does not move towards SDGs, we are not going to have a healthier planet or healthier populations. And the reason I'm saying is MDGs were primarily focusing on the ministries of health. SDGs and the primary health care involves community, people, and the population. And that's one of the challenges, the 6 building blocks the WHO has been promoting. Those 6 building blocks, sadly, don't have anything about people or population into that 6 building blocks. So what we need to do is, I think we need to, and it needs a shift in the mindset. The people over the years, especially the public health community, and I know you are a cardiologist, I know you are an epidemiologist, but you are also the biggest advocate globally and nationally for stronger health systems. We have over-medicalized the health system. You go to the district health office anywhere in India or any other part of the world, they are only doing the medical thing, vaccines, drugs, supplies. Historically, district health officer was responsible for water, sanitation, and everything which will contribute to the health, which is in fact now the SDGs. So I think we have to come back to that reality that we need to involve people, we need to involve other sectors, and there's much more which contributes to the health than just the domain and the decisions of the ministries of health. So Professor Reddy, if you don't mind, can I ask you a question regarding this?
Sure.
Okay. So with the COVID for the health system, you just mentioned, what do you really feel? I just want to flip it. Are COVID's key lessons in the health system, either about the SDGs or the overall universal health coverage or the primary health care? What do you think?
Let me start off with where you left, the role of the community. I think that's absolutely important. It's very clear that whether it is very early recognition of symptoms for reporting, early diagnosis, and therefore early testing, also revealing who the contacts were so that contact tracing can be efficiently done, for removal of fear and stigma in the population, for removing vaccine hesitancy. All of these are essentially functions of the community. And without that, a health system can only function with very limited efficiency. And therefore, engagement of the community in any health program is absolutely critical. And that's one thing that has come about. I mean, if the community decides that they're not going to wear masks or wear masks properly, despite all the regulations and diktats that may come from the authorities, then there's very little you can do. Or if the community decides that they are going to have super spreader events and not follow the advice to stop crowding, then there's nothing you can do. Therefore, having the community as a very important partner is absolutely critical. I think that's one of the lessons. But I have a few more to add. Firstly, I think we need a well-functioning health system, well-resourced and well-functioning health system, in the steady state, if you have to create a swift and strong surge response to meet a public health emergency, whatever be the nature of the public health emergency. It may be COVID, it may be a natural disaster, whatever. Without that, you'll be still floundering around and having a very hurried assembly of actors, which is going to be very inefficient. The second is primary care is absolutely critical. And it is primary care that must lead. For all the reasons I mentioned, for the community, all of these are functions at the level of the primary care. And you are absolutely right. The MDGs fragmented the agenda, whereas in a family, you're not really looking at only one disease vertically. You're looking at multiple health conditions. You're also looking at the social determinants like water, sanitation, nutrition. It is the family that represents the essence of the SDGs. And therefore, community comes in, primary healthcare, which actually engages with the community and serves the community closer to home or at home, is going to be critical. Secondly, the other factor is that we need the public sector to be strong. We cannot have a health system which is going to be divided between an entirely autonomous private sector and a relatively weakly resourced public sector. We have seen what has happened in the US, whether it is the response of the hospitals or the response in terms of the provision of the various kits, and now even in the whole area of vaccine supply, actual administration of vaccine, they're floundering. UK did even worse. They contracted everything out to private sector, and many of them had no experience in the health system also. So unless you have an organized public sector which is strong, which can bring in the private sector to act responsibly as a partner on its own terms, we will not have a well-functioning health system response to pandemics like this. I think these are my lessons from COVID-19.
Okay, so I think that's very good.
But let me also ask you about one area that you have been talking about, building the capacity in the health system itself for managing some of the challenges that I also alluded to, the whole area of supply chain management. Somehow in the public health training or in the medical training, the area of supply chain management doesn't come in, and you entirely depend upon people outside who have very little experience of the health system. And then you start looking for test kits, you start looking for ventilators, you start looking for a variety of things, or even supply chain management of human resources in health. You're very short of health workforce. So how do you actually address this in the health system context? How do you build that capacity?
So, Professor Reddy, I think this is a very important point which you are highlighting. As I said, most of the people in public health are still medics. And I'm a doctor, but you're a doctor. But I think we need to have more and more diversification into the public health. And the problem is the doctor still wants to have medics, doctors, nurses, and others wants to keep a monopoly because we believe the whole health system is based on the infectious disease model and the germ theory. And that's where the most of the health systems has been designed. But we have realized during this pandemic that we don't have any expertise, as you are alluding, in supply chain management. There's no school of public health who teaches supply chain management all over the world. There are some schools who elaborate some case studies during the access to medicine or the logistics and other stockouts. And this has become very clear that there happens some sort of a serious challenge in each Ministry of Health, from the West to the North and the South to the East, that how can we distribute and deploy the people? How can we distribute, procure, store, and distribute the equipment? And what are those supply chains? That is a new reality. And I hope somewhere people will realize and start investing in this area of work. I know some schools of management, they do teach supply management, and there's some concentration even on health sector. All the pharmaceutical people are trained there. However, you mentioned the health workforce, and that was another chaos. Who are the people we should train or train to deploy to respond to the pandemic? And that has been a very difficult because there we also failed. Are people really trained? However, this is not the area where we invest a lot. There are other colleagues in the WHO. Where we invest is for stronger capacity to generate locally contextualized knowledge. And that I think has become very evident. And we commissioned 14 studies in 14 countries in all over the world, just to understand three things: how the policy and the decision making has been confronted and how the governments reacted to respond to this thing. The second question was how the vulnerables or otherwise marginalized populations were protected, and how the governments were able to maintain the essential health services, because epidemic is there, but there are people still suffering from diabetes, from hypertension. They have to go to the hospitals, and for a larger part of the world, they were overwhelmed, and people have suffered who were suffering from non-communicable diseases or the chronic disease, or even for malaria or the routine vaccination. So what does it tells us is that we need to invest more and more in the local knowledge and more engagement on the demand side, because this is not something where we are testing hypotheses. This is where we are responding to the needs of the people and the demands of the policy and the decision maker. And there we need very different type of capacity and the science. The people who can use systems lens, people who can use transdisciplinary approach, because not only epidemiology, you need a little bit of understanding of the public policies, social science, epidemiology, economics, everything. And that is where we have been investing, and we are happy to see in some of the areas where we have made investment, the response has been much better and the knowledge generation have been much quicker. Even in India, we are working with the Ministry of Health, and they asked that team to develop a rapidly reviewed like a response article, and they were able to do in 48 hours based on the deployment of the health workers. I think those are the capacity we need to have, and those are the capacity we promote, and we should be doing that.
I entirely agree with you. Multidisciplinarity is absolutely critical for public health and health systems and health policy. In fact, any enlightened policy should have scientific credibility from epidemiological and clinical and biomedical research, financial feasibility from health economics research, operational steerability from implementation research, and political viability, judging whether the community is ready to accept it, who are the people likely to support, who are the likely people to oppose. That will come in from social science research. What are the barriers? What are the solutions? I think all of these streams of knowledge must come through. But one of the elements of research is the moment you talk about research and policy, it appears to be a little esoteric. It seems to be a little more of an ivory tower exercise of academics. But you want to, through the alliance in WHO, bring it right down to the ground level, real world situations through implementation research, demand responsive research, embedded research. How does that work?
So thank you, Professor Reddy. That you are alluding, as I said, everybody who is in the public health or in the medicine, we were taught into the schools of medicine and schools of public health that randomized clinical trials, RCTs, are the gold standard for research. And that's true. However, that's only true if we are doing some sort of basic science biomedical research. Like if we want to have a clinical trial of the statin, if you take a statin, does it reduce your cholesterol or it does not reduce the cholesterol? And that works very well. What we need to have confront the different questions of the challenges in policy research or the systems research. And I can say it with certain confidence, but I hope you will agree that if there's something proven effective, which is a systems or policy outcome in Punjab, may not be equally effective in Maharashtra or UP. And the reason is the context is very different. The culture is very different. People's perceptions are very different. Supply chains are different. Deployment procedures are different. So I think it gives me immense pleasure that you are the main author for the WHO strategy on health policy and systems research entitled A Changing Mindset. And there's a chapter in that says coming of age, because historically we always feel little defensive with our peers in the medical schools or the public health school or the research community, because this systems research, policy research, implementation research is a fluffy science because they only think RCT is the best. And in that chapter, which is coming of age, we decided that why do we have to keep on comparing ourselves with RCTs? Because there's a systems research and policy research in the education. There's a systems research and policy research in agriculture. So since then, we have developed the new science, and that is what we call is the demand-driven research, embedded research. And what we mean is historically the biomedical research or the basic research or the RCTs, we test hypotheses. Here we answer a question, and that is where we have changed the shift of power. It's not only somebody sitting into that ivory tower who is academic and a bright professor. No offense, people go to those research positions because they want to use whatever they think is a good question, have a publication in the Lancet or New England Journal of Medicine. That's wonderful, and we should have it. But I have yet to find a Secretary of Health, especially in LMIC, who reads Lancet in the morning. They read local newspaper where the data comes, what is happening in the different states and the districts. So there we said that the power of setting the research agenda should be with the policy and decision makers. And that is what the demand-driven research is. They decide what are the research questions, and then obviously researchers help them to articulate, to make it a perfect research question. So that's the priority setting. Then they are also part of the research. We don't want to make them researchers, but we have at least worked in 100 different settings where district health officers, program managers, and in some cases, even director generals in the ministries of health has been the PI with the researcher who was embedded into that research. And what happens then, we don't have to make any effort to ask them, sir, here is the result which I published in Lancet, and it's very interesting for you. In fact, he has or she has identified the problem. He or she has identified what is the research question. So it solves his or headache. Then I am telling him that, sir, it is good for your headache. And that has completely changed the power dynamics. But we have to struggle and confront with some of our colleagues who still think it is very, very linear thinking. It's like a biomedical research. But I'm happy to say now that it's not only us within the WHO, it's the UNICEF, it's the USAID, it's the Doris Duke Charitable Foundation, it's Gavi, and then there are a couple of national governments who are fully supporting the demand-driven and embedded research. And I think that's a one big thing that we think will improve the performance of health system.
Well, a difference, to make a difference, must be something that has to solve problems. So if you're talking about problem solving, then you clearly require research which is grounded in real world problems and can deliver evidence informed, context relevant, resource optimizing, culturally compatible, and equity promoting recommendations to policy and practice. You emphasized context quite a lot, which is absolutely important. But you're also sitting in WHO promoting global partnerships, global knowledge sharing, global alliances, even in this kind of research. And we know that even in universal health coverage, there have been some important global learnings. Like, for example, user fee. Initially, most governments and even some economists and health experts said user fee is essential. But later on, it was found that user fee is counterproductive. It shuts the door on the poor from accessing services. And in a strange synchrony, both WHO and the World Bank said user fee is inefficient and should be done away with. Same thing with single payer system in universal health coverage. Basically, it has been said, irrespective of who is financing health, whether it's taxpayer funding or employer funding or even private purchase, single payer systems bring in much greater efficiency. So there are global experiences also we learn from. So how do you actually accommodate context in terms of global knowledge sharing?
So I think it becomes really a challenge because, as you know, like global knowledge, one of the things is like we do systematic reviews or the meta-analysis, and those are easy to do if it is something about like a drug or biomedical intervention, and that's very important. Please don't misread me that undermining the power of the RCTs or the basic science research. However, I think we have invested as an organization, the WHO, in establishing the systematic reviews for the health system research synthesis, and the rapid reviews. And there's a new science which is being developed, and then we can do with a reasonable confidence some sort of like systematic reviews for the global literature. The challenge, I think, to me is, while you are saying, is the context, that I don't think there would be ever that we transfer one experiment, let's say from Bangladesh to Burkina Faso or Ghana to Guinea-Bissau. And that makes it a challenge. However, there are a lot of other ways to do it, that we don't have to have the systematic reviews, but we can do some sort of, we can have something, what are the principles we can learn, and we can develop those principles and share with the policymakers that, sir, madam, if you do this thing, there's a high probability of success. If you take this path, there's a pretty good chance that you will fail. And I think that science is developing slowly, and there's a broader agreement, and we are learning from the management schools and the public policy schools and the public health schools. So you have been a faculty at the Harvard School of Public Health, but the Harvard Business School, they only teach case studies. And that's the way they train people, and that's the mindset they come out, and then they say, this is how you have to promote the knowledge and the thinking. So the second challenge that we have is, as I said, and I even at the risk of repeating, what is happening in the global health community. Before 1982, WHO was the biggest global health entity or the authority, and then the World Bank slowly started becoming a big power. And the World Bank, as we all know, are basically economists. And I just want to apologize the colleagues who are economists on this like webinar. I respect them. However, what they have done, all the models of the health system design and evaluation and measurement and monitoring are very linear. They say this input, output, outcome, and impact. It works very well for efficiency and effectiveness, but they undermine that when we move from the output to the outcome, there are 100 other things, which is a context, systems readiness, availability of drugs and supplies, availability of staff, motivation of the staff, all those things, and the community and everything. And this does not work. And I think that is a shift we have to do. And especially if we want to make the system which is helpful to the local population, it is more equitable, not economic equity at the input level, but the equity at the outcome level. And that's a very different equity which we want to have it. And I think slowly the economists are realizing, and it gives me the comfort. One of my professors was the president of the International Health Economics Association, Professor David Bishai. And once he heard me talking this thing, and he came to me and he said, please say it more and more because I cannot say it. But this is a good thing to tell to the economists, that linear model, perfect for efficiency or effectiveness, but does not work that well if we really want to improve the health of the people, especially at the local level design and monitoring of these things. So there are movements, there are things happening, and with the SDG, I think there are new tools and there's new like mindset which is coming to do more, because one thing within the SDG we have to understand, it in fact threatens the government and gives more power to the society and the people, and that's a good thing or the best thing about the SDGs. And I think the people will change despite the importance that we trust, and we need to have a much stronger public sector for the health. Back to you, Shinar.
So I think the point is very well taken. Context matters, equity matters, and health systems must actually take all of these into account and not follow linear models. But global knowledge sharing becomes important too. And we pick up lessons, we adopt the principles, adapt the instruments, and apply in the specific context to get the best results. But ultimately, it is the local stakeholders who have to decide how best the programs will have to be configured, and the research also must also adjust itself to those requirements and demands. And I think that's an excellent way in which health systems need to be configured much closer to the ground level rather than to the ivory towers of the academia. I fully agree with you.
So Professor Reddy, sorry, go ahead, because
Go
I
ahead,
think
go
we're
ahead.
close to the thing and I have a question for you, but please close your like.
No, go ahead, go ahead.
So I'm just realizing, I think we have a few minutes left. And everybody knows that India has invested the biggest like USC budget in the whole of the world. And I know for sure you have been one of the architects or the thinker behind the USC. And you also has written a book, Make Health in India. And before we close, I just wanted to hear from you that we have talked about the global things. What do you think what are the more important things? What are the few important things in your book, which are good for the Indian people and the politician, but also for the global health community?
Well, I think we have learned from many other countries too and looked at their experiences, both of the rich countries as well as the middle income countries and the low income countries. But some of the key principles that have emerged is that you need to have health systems, particularly for universal health coverage, which are substantially tax funded. Depending upon only private contributions to purchase insurance never works anywhere efficiently. You get a large number of people disenfranchised. And as one of my former mentors used to say, you need more money for health, but you also need more health for the money. That means allocative efficiencies and utilization efficiencies are important. And there, primary healthcare becomes absolutely important, because in terms of population coverage, everybody in the population requires primary healthcare some point in time or other, whether it is immunization or whether it is a cut that needs to be sutured or a normal delivery. Primary healthcare becomes absolutely important. then you have in primary healthcare the largest package of services, whether it is mental health or diabetes or hypertension or anemia, every one of them is actually at the primary health care. And it's also the most cost optimizing measure of the health system in terms of use of resources that are available. So I think one of the messages that comes out in the book is you do need very strong primary healthcare system, but well connected also to advanced care in secondary and tertiary levels, not disconnected. And you need to bring in all healthcare providers into one system. And particularly if you can use what we call a bundled system of payment for a set of services rather than user fee for each individual service rendered, then you have a better utilization of resources. But the key message is it has to take equity into consideration. It has to be grounded in social solidarity, because without social solidarity, the principle of cross-subsidization in universal health coverage will not work. But without universal health coverage, you can never have an efficient and equitable health system. And therefore, everybody will suffer. Even the rich will suffer if you don't have that kind of health system. So I think that is something that I put in my book, essentially drawing upon global learnings, but trying to position it in the Indian context.
Thank you very much. That's very helpful. Thank you.
Thank you, because the world of systems and policies appears to be rather rarefied. You have brought it very much to the ground level. You taught us that actually it is problem solving at the ground level, identifying the problems of the community, identifying what the priorities of the policymakers and the implementers in the health system are, working with them collectively, bringing in the strength of the academic community, but bringing also the rigor of research into solving practical problems and coming up with implementable solutions. I think that is very important for health systems and policy research. And you are setting an agenda which is going to be really helpful for health systems across the world, particularly in the low and middle income countries. So thank you very much for that.
Thank you.
Rupaji, are there any questions that we would like to take from the people who have been listening to the webinar?
Yes, thank you very much, Professor. There have been questions on YouTube and on Zoom. I'll just put the first one to the both of you. Someone anonymously says, agreed, COVID-19 has shown that the community is important, indeed crucial, in dealing with a public health emergency. But how does one operationalize community participation in public health and not just in an emergency?
Well, I'll offer one initial reply and let Dr. Ghaffar proceed also. You see, communities have to be regularly engaged in the health system, not just be called upon in an emergency. We know that there are places even in India where Kerala, the panchayats play a major role in deciding the health agenda as well as in the implementation. We know that in Thailand, there are also village health councils, regional health councils, and annually there is a National Health Assembly of people drawn from different constituencies, community representatives and NGOs, academia, the health system managers and implementers. All of them sit together, the health professionals, the healthcare delivery people, all of them sit together and review what has happened in the previous year, where the shortcomings were, what are the solutions, what is the next year's agenda. In Brazil, municipal health councils also do that on a monthly basis, and there's an annual review. So the community has to be constantly engaged, even in a representational form. But I believe the community voices are closest to the primary healthcare providers. Your ASHAs, Anganwadi workers, your auxiliary nurse midwives, they are the people who are actually gathering the views of the community, assessing the needs of the community, and we must also draw upon their experience to actually identify what the agenda should be. Dr. Ghaffar?
So I think like NCR, there are people in fact build these relationships during normal periods, peace times, emergencies, people get together. This is a fear and that's a basic instinct. However, as Dr. Reddy was saying, there are a lot of examples in different parts of the world where people start trusting each other, build this kind of contacts, and work together as a community. The challenge is that if we want to do the medicalization through the community, it becomes a bit of hassle or a challenge. If we want to improve the health of the people, that's altogether a different thing. And people do healthier things, and there happen examples in India, in Bangladesh, in Thailand, in Africa, everywhere. And that I think with especially the NCDs, there are more and more communities getting together, doing exercises together, looking for the food which is better for the community, for the people. And I think that's the mindset we have to change. When we look at the health, we look at the sickness. See, and see, the Ministry of Health primarily is the ministries of sickness. They are not ministries of, they only treat the people. So I think with the community, there's a desire, but there is a lot of literature. If somebody is interested to read that, there's a lot of literature on this thing which can improve the community participation and engagement to have a better health during the normal periods.
In Uttar Pradesh, women's self-help groups have been engaged by some of my colleagues, and they took in messages for maternal health and care of people in pregnancy, and that actually reduced the maternal mortality and neonatal mortality because of their engagement with the overall community. So we can actually look at a number of mediators like that. And I believe within the community, there are many resources that are underutilized. In Iran, for example, the urban primary health care, there are a number of women volunteers who actually engage the community in nutrition, in child care, in physical activity outdoor. I've seen them happening, and ultimately the urban primary health care system also came alive because of their participation.
Right. Dr. T.V. Gopal from Anna University asks, how and why did the present medical system become super specialty based? How can it become multidisciplinary on an exigency basis?
Dr. Reddy, go ahead.
Dr. Ghaffar, would you like to?
No, please go ahead.
Well, I think unfortunately, as Dr. Ghaffar said, we have looked at the health system as looking at illness care. And because the primary healthcare system has been inefficient, the illness actually becomes advanced to a state where you have to go to a large hospital for treatment of complications that should have been prevented in the first place. And therefore, people who are actually in specialist practice acquire a larger than life image. They are doing wonderful things. They're saving lives, no doubt about it. But they are at the apex of the entire process, and they're not at the base of the entire process, which is the primary health care. So unfortunately, the attention has got focused on that level of illness care, and we have therefore accorded a much greater decision-making power or decision-shaping power to them as well. I think if you have a very strong primary healthcare-oriented health system, then you can actually bring in all the other elements and make it much more broad-based rather than becoming very specialty-oriented. Specialists are required, but then they have their own role. When you take a family into consideration, somebody has diabetes, somebody has hypertension, somebody has a pregnant lady who is about to deliver, there is a child with a respiratory infection, but all of them are also looking at how to promote their own health. And all of these will have to be tied together, and no single specialist can do that. And even as people age, they have multiple health problems. No single specialist can tackle all the comorbidities. So bringing in primary care in all of its dimensions is going to be the critical solution for advancing our health system. And we should not be entirely focused on diseases in a siloed manner.
So I think that's absolutely true, but I would just like to add, I think we need to understand in which environment the primary healthcare system and the super specialty work and the interdisciplinarity is. There are issues of incentive, and healthcare is not a perfect, like in the economics, an imperfect economical like industry. People make decisions, and there are people who have higher incentive to provide the super specialty care because you can make more money or more profit. However, if we want to do the health, improve the health of the people, and as Professor Reddy was saying, the family, and all over the world, we all know now more than 50% of the global population is suffering from the chronic diseases, which is diabetes, hypertension, cardiovascular diseases. It is not a treatment that super specialty needs, that you go to a doctor and you get a surgery or you get something and your fever is gone or your headache is gone. These are the diseases which will live with you for life. You have become effective with those things. So there we need the transdisciplinarity, multidisciplinarity and engagement of the population. But what is happening is there's a profit, consumerism, and that is driving a lot of like healthcare industry towards those super specialty and the super hospitals.
There are two questions which are related. I'll read them together. The first one is, the question is for Professor Reddy. What is your opinion on involving private parties in primary healthcare? And what is your opinion on the change in the role of government from being a health provider to a health insurance provider? And the second question is, what will be the role of the insurance sector in making healthcare universal without it being unethical?
Well, frankly, I believe everybody who is capable of providing health services should be brought into the picture in a unified format of universal health coverage. But the public sector has to take the lead, set the agenda, and bring in the private sector as a responsible partner, which is also delivering the services that are commonly agreed upon with clear accountability mechanisms. It can't be a fragmented system in which there are multiple players doing multiple things, and that won't be universal health coverage. So even in primary care, we can and should bring in the individual primary care providers into a network. After all, in the United Kingdom, the people in the NHS, all the GPs are essentially private practitioners, but they're all adhering to the system that has been laid down by the NHS, the National Health Service. So we can bring in people, but they have to adhere to the agreed format of universal health coverage and the services to be provided with clear-cut accountability mechanisms. As far as the insurance question is concerned, I do not think in India you can really have a private insurance system or even a social insurance system with where you are going to depend upon salary deductions. 90% of our people are in the unorganized sector, and quite a large number of them are also poor and they can't pay individual contributions. And therefore, we need a substantially tax-funded system in which employer-provided insurance and private insurance can be supplementary mechanisms, but they can never form the main vehicle for delivering universal health coverage in this country.
We have time for one more question. And it is, with the COVID experience till date, there has been more medicalization rather than demedicalization of society. How do you respond to the situation?
Dr. Ghaffar, maybe.
So I think it is also an issue of marketing and the medical profession. You know, like before 1983 or 4, American Medical Association was the biggest contributor to the presidential election campaign in US, because doctors wants to keep the monopoly as a profession. That everything becomes medicalized so that they can make money. It's not only the doctors. Doctors are just one part of that. There's a pharmaceutical industry, and they're also very powerful. The issue is, as I said, historically, the health systems were organized based on the infectious disease model of the germ theory. And the common person on the street or in the house thinks that doctors or the medicine can relieve my pains and suffering, which is true. There's no question about that. However, with the non-communicable diseases, I just want to repeat it again. With the malaria or TB, you go to a doctor, you take the medicine, and you are fine. With the chronic diseases, you have to stay on some sort of medicine, and people don't realize it. And that is where we are, as the health community, we are making it more and more medicalized. This test, that medicine, this medicine. And we are not investing either as a society or the people who are regulating the health within the country, that we should invest more and more in the non-medicalized things, which ultimately would be much more cost effective and much more cheaper, and it would be less painful for the people. But it is the mindset, the way it has been done by the consumerism over the years, that for a commoner, it's very difficult not to be victim of medicalization. It's a long effort, but there are consumer society, patient societies, and the governments now are investing in this thing. And I think that slowly there's a recognition even in the medical community. Professor Reddy?
I would entirely agree. I certainly believe that communities would certainly take a broader view of health than the healthcare providers who are particularly interested in providing specialist medicine. Specialist care is important, is life-saving, but that cannot be the sum and substance of all healthcare or even health services, and there is health beyond healthcare. But even coming to healthcare, if you look at COVID, which is the question, what the questioner asked, 80% of the people don't need hospitalization. Most of them are either asymptomatic or mild and are taken care of at home, which means primary health care. People who get sick and may have longer lasting symptoms, what's called long COVID, they're not going to be hospitalized. They need care and advice at home. So there are many functions, even in COVID, which are actually to be done at home. Immunization, contacting is a primary healthcare function. Unfortunately, it is the clinical trials and the ventilators that sort of get the attention. They're important in saving lives. But the bulk of care, even in COVID, is at the level of primary health care. And that is the message that must go. Unfortunately, that is not reflected in the media. And therefore, people think that ultimately whatever matters is the hospital. But we know that's not true in COVID too. So I think we definitely need to strengthen our primary healthcare system. And that will be the important element that we need to bring in. For example, our urban primary healthcare systems are very relatively unfunded and poorly organized. And if they were much better, we could have controlled COVID much faster in our urban settings, even when it entered in the first place.
Thank you very much, Professor Reddy and Dr. Ghaffar. I'll now invite my colleague Moina to join us for the vote of thanks.
Dr. Ghaffar and Professor Reddy, thank you so much for that insightful useful, informative, and very thought-provoking discussion. I thank all my colleagues at Orient Black Swan who have been involved in today's event, and to all members of the audience who have joined us today, and to those of you watching us live on YouTube, a very big thank you. We do hope you have enjoyed today's discussion, and we hope you found it useful. Please do share the link with friends. Thank you once again, everyone, for joining us. Wish you all a pleasant evening. Take care. Bye.
Thank you.
Bye. Thank you.